Howdy, y'all. Today we're going to be talking just briefly about some of the readings in Section 1, Part 1 that deal with the competing sort of conceptions of how to approach medicine. The historical one being sort of paternalism and its sort of tension with the value of autonomy. Okay, so we'll start with just the idea of sort of paternalism, which historically has been sort of the way to approach medicine. So under this sort of conception, medical professionals act as parents, right? That's where paternal comes from, and the medical decisions are being made for the patient's own good. So we put primacy on the decisions of the professional, and we regulate the patient's sort of choices to an inferior role. Um, so the idea here, at least the ethics behind this, is that the patient's well-being is the primary goal, and that puts the paternalistic model in the realm of the sort of the consequentialist utilitarian moral traditions. Is that what we're trying to do is maximize well-being. We're trying to make the world a happier place, and the concern here is that well-being is being sort of equated with physical health. Is that if it's a kind of narrowly defined, that well-being and physical health are basically sort of the same thing. Um, and the worry is that patients lack the expertise and will make sort of suboptimal choices, at least with regards to their physical health. But if you equate that with sort of well-being, um, then uh, you will have a sort of a moral directive to listen to the medical professionals, right? If their choice is going to be sort of better in terms of getting the right sort of physical outcome, and the right physical outcome is equated with sort of well-being, and your moral goal is to maximize sort of well-being, then that seems to lead to this sort of paternalistic model. And then historically, as I sort of mentioned, this is sort of the model that medicine has approached, and the Hippocratic Oath, the old Hippocratic Oath, is sort of an exemplification of that paternalism. So you have in your reading today a version of the Hippocratic Oath. It's not something that too many sort of medical professionals take seriously this day. The oath, that is, not necessarily the thinking behind the oath. But there it is, right? It gives you kind of a sense of a starting point of, let's sort of think of medicine in this sort of paternalistic way. Let's think of doctors and other medical professionals as experts who are going to sort of know best about what is going to um, be most appropriate in terms of the physical well-being of the patient. And again, if you're sort of a utilitarian or sort of consequentialist, that might matter the most, right? That might be sort of the primary sort of moral uh, point of decision making. Okay, so what are the problems with paternalism? Well, the basic theme here with the reading is that paternalism and this sort of consequentialist tradition doesn't make enough room for autonomy. So autonomy is the ability for people to sort of make their own decisions. It is an appreciation for self-determination, for self-governance, and for the freedom of will. And if you think that that's important, however you understand that importance, then there seems to be sort of a conflict with paternalism. So a very sort of simplified argument against paternalism would run something like this. And again, this is pretty vague, but just to get the argument sort of explicit as possible, I think it could run like this. So we've got a couple premises here. We've got more or less sort of a statement of a necessary condition for the appropriate approach to medicine. So as I have it written, the appropriate approach to medicine must give adequate weight to patient autonomy. So another way of sort of saying that would be in the classic sort of if-then sense, that if something is the appropriate approach to medicine, then it gives adequate weight to patient autonomy. So take that along with the second premise, which is the denial that paternalism gives adequate weight to patient autonomy, and you would get as a result that paternalism is not the appropriate approach to medicine. So the problem with paternalism is that it doesn't give enough weight to the ability of people to make choices for themselves. And that's basically what's going on in the Goldman piece, that the refutation of medical paternalism goes through kind of a positive case in favor of paternalism. About, kind of goes through and explains why you might think that paternalism is the right way to go, but again, because the positive argument sort of ignores the value of autonomy, it's sort of regarded as sort of a failure. But we want to kind of be sort of clear about, well, what is the problem of ignoring autonomy, or putting autonomy as sort of as a lesser value than physical well-being? Well, one issue is comes back to this equation of physical well-being with well-being, that most theories of well-being, or sometimes just referred to as sort of theories of happiness, will take issue with this idea that the only thing that matters in life is your physical health. And so part of the problem with that equation is that, well, autonomy plays a role in your well-being beyond just your sort of physical health. So everything may be going sort of perfectly fine for you sort of physically, but you may be doing sort of poorly in the sense that your desires aren't being satisfied, or in the sense that your autonomy is not being sort of respected. So respect for autonomy can kind of play a role in how well somebody is doing. And if the goal here, in terms of sort of treating the patient, is to raise their well-being, and you're only looking at sort of one aspect of that well-being, and you're sort of missing that desire satisfaction piece, or that autonomy respecting piece, then you're only doing sort of half the job. So again, this keeps us within a certain sort of way of thinking, is that, okay, our moral goal is to maximize sort of well-being, and so it's still kind of consequentialist in nature, but nevertheless it sort of says that autonomy is part of that picture, and it needs to be sort of considered. So that's sort of one way to think about it, but another way to think about it is that autonomy is itself a distinct and sort of fundamental moral value that cannot just be reduced to well-being. That is not a part of well-being. It's actually something different from well-being that has moral value of its own. And if this is the case, then this sets up this kind of balancing act between sort of two fundamental values. So on the one hand, you have sort of the patient's well-being and their happiness, and on the other hand, you have sort of respect for their ability to self-determine themselves, to self-govern. And this is kind of the moral tradition that you sort of hear this in, is the Kantian sort of moral tradition. In fact, Kant's own sort of moral theory puts very, very little weight on well-being. In fact, almost no weight on well-being. And for him, all of our moral directives come from respect for autonomy. So one of Kant's formulations of his fundamental moral principle, which he calls the categorical imperative, is the humanity formulation. And the way that Kant sort of puts it is he says that we must always treat others as an end and never as a mere means. And what that entails is that everything that we do involves respect for autonomy. That has to be sort of the primary goal. So for Kant, there wasn't much of a balance between autonomy and well-being, but for most other folk, these are sort of sometimes conflicting goals, right? There's the trying to look out for what's best for the patient, and at the same time respect for their autonomy, and you can't always sort of do the same thing. Okay, so to end this out, we're going to talk a little bit about how you might approach this balancing act, that the different ways of sort of conceiving your model for the patient healthcare professional sort of interaction is a way to kind of just sort of think about how we sort of might approach this. And this is sort of the reading that sort of covers this is the four models of the physician-patient relationship by E.J. and L.L. Emanuel. And what the authors here are doing is to sort of start off with just sort of a taxonomy of views of like how you might sort of approach the physician-patient relationship. And they say that, there are probably sort of situations where one of the, like all of these models are to be preferred. So sometimes you would go with one model and sometimes you go with a different model. But their primary argument is that the deliberative model, which we're going to sort of talk about here at the end, is overall sort of the best model, that the best way to sort of conceive of the physician-patient relationship is using the deliberative model. But part of their argument, it just sort of helps to kind of see, well, what are your other options, right? What is this deliberative model to be sort of compared with, and to try to understand, well, what is potentially sort of problematic about the deliberative model. So let's just sort of start by saying, this is about finding the correct balance between well-being and autonomy. And the first model, which we've already discussed, the paternalistic model, is one that puts most of the weight on not only sort of well-being, but physical well-being, right? So the paternalistic model is not as concerned with sort of patient autonomy. And again, this understanding of the patient relationship is sort of understood as sort of as a parent role or a priestly role, at least according to the authors. So is it ever okay to be paternalistic? Sure. There are some situations where patients lack autonomy, that you have certain situations where through some sort of cognitive disability, or some sort of degeneration of I keep on wanting to say ability, but some degeneration of capacities. You just may be in a situation where there's not much autonomy there to begin with, and so not much to respect, and so maybe the paternalistic model is just fine. But again, for people who have autonomy, you'd have to weigh well-being against autonomy, and so these other models are attempts to kind of think about, well, how that might sort of work out. The informative model is, and again, I'm using their language here, as otherwise understood as the scientific engineering or consumer model, is recognizing that the doctor has some expertise, but sort of thinking of the doctor as just sort of an information source, right? So here's this doctor, just like you'd use them for in any sort of a consultation, and they would say, okay, well, just give me the information, right? What is for some sort of treatment? What are the risks? What are the options? How long does it take to do? What is the prognosis? How much does it cost? Right? All this sort of stuff is just, you just go to the doctor to get this sort of information. And then that's the doctor's sort of entire role, that the doctor really sort of plays no role in coming to a decision beyond giving that information. So the decision is thus sort of left to the patient, right? So we put a lot of weight on patient autonomy, and leave the doctor almost sort of completely out of the decision-making process. So this may be sort of understood as sort of the opposite end of the extreme here, right? So on one end of the extreme, you have the paternalistic model. On the other hand, you have the informative model. So these other two models then are going to be sort of somewhere in between, that they're not quite the paternalistic model, not quite the informative model. So one way to kind of go in between here is to do this interpretive model, or which the Emmanuels call the counselor model. And in this case, you have a doctor or a medical professional who isn't just there as a source of information, but also kind of is there to sort of help the patient sort of talk through the decision-making process, right? Just to get a sense of what the patient's values are and what their goals are and what their desires are, right? So what are the things that they want? And how does that sort of interact with the options and the choices and the risks and so on and so forth. And so there is this sort of added role to the doctor, and this is what's going to differentiate the interpretive model from the deliberative model. The doctor doesn't actually make a recommendation. So at that point, the doctor kind of helps them sort of think about it, and again, sort of says, what the facts are, but also tries to get a sense of what the patient's own sort of desires are, but stop short of actually sort of saying what the doctor thinks would be sort of the most appropriate course of action. So the deliberative model then would be that sort of one step further. So the deliberative model, and again, this is where the controversy lies. This is where the argumentation needs to occur. The deliberative model would say, well, not only does the doctor do all this stuff from the interpretive model, but also sort of at the end of the day sort of says, well, this is what I would do, right? This would be what I would recommend as sort of the best course of action. So it's a little bit different, and it's a little bit more sort of controversial as a result, and it's the thing that the Emmanuels sort of argue for. This is what they think at the end of the day is the best way to approach medicine. Okay, well, that's all I wanted to discuss today. I wanted to keep this around sort of 20 minutes, and I'm getting close to that number. So I'm going to sort of leave it there. I might have another video for you to watch later, but for now, this should be enough to kind of cover just the basics for this this first section. So section 1, part 1, or so section 1, part 1 is pretty much this, plus the case studies, which we'll talk about sort of separately. All right, good luck.